We've got about 24 slides ahead of us, so if you will, just save your questions for the very end and we'll get those answered for you. First up, oxygen should always be treated as a medication. It must be ordered, monitored, titrated, reassessed, and documented. Most acutely ill patients target an oxygen saturation between 94 and 98%, while many COPD patients should be maintained between 88 and 92, unless otherwise ordered. Staff should always treat the patient's clinical conditions and not rely only on the pulse oximeter number. One example of that would be carbon monoxide poisoning. Another example is keeping the respirations normal. We know the patient can increase that number to compensate, but we want the patient to be breathing at a normal rate. We want to add oxygen, even though the patient is maintaining their SpO2 at 97% with 26 respirations. Got a little question here to get those brain juices flowing. We have a patient. The patient is ordered to receive approximately 30% oxygen through nasal cannula. Based on standard oxygen delivery estimates, how many liters per minute should the nurse set the oxygen flow rate to? We got 4 answers here. What do y'all think? We'll pause for about 10 seconds. If you guess C or meant to pick C for 4 liters, you are correct. Room air contains approximately 21% oxygen. Adding that nasal cannula and bumping up 4 liters will give us that targeted oxygenation percentage. Normal atmospheric air is mostly nitrogen. As said before, air contains about 21% oxygen. And for every liter of oxygen delivered to the patient's nasal cannula, the percentage of O2 will increase by 3 to 4%. Notice there is some other really small contaminants: argon, carbon dioxide, and a few small traces of gas. Common oxygen delivery devices include nasal cannulas, simple mask, Venturi masks, non-rebreathers, high-flow nasal cannulas, nebulizer mask, and bag valve mask. Each device serves a different purpose depending on the severity of hypoxia and the patient's respiratory demand. The mask on the left is a partial non-rebreather. They make these so that the patient won't suffocate if it's placed on the patient before filling the reservoir. This mask only provides up to about 80% oxygen because they have an open valve on the left side without flap. Both sides must have the one-way valve in order to take in the concentrated oxygen from the reservoir. On a side note, a partial might be more fitting for a COPD patient. All one will do is remove one of the valves on a true non-rebreather mask, making it a partial non-rebreather. Nasal cannulas are used for mild hypoxia and usually run from about 1 to 6 liters per minute. Oxygen concentration varies because of the patient mixing the room air with the delivered oxygen. Simple masks require at least 5 liters per minute to prevent rebreathing of carbon dioxide. Don't forget to add the hydration for the nasal cannula for anything greater than about 4 liters. One thing to note is the criteria for these 2 devices. The nasal cannula could be applied if the patient is hypoxic or has a high respiratory rate. But when would a nurse jump straight to a non-rebreather? Non-rebreather is for a patient pending respiratory failure. Keep in mind that we are treating both the monitor and the patient. If the patient has a SAT of 85 but is breathing at 16 respirations a minute, nasal cannula might be a more suitable device. However, if the patient has a respiratory rate of 32 to maintain that 85%, they'd stabilize better with a non-rebreather, so they're taking in more oxygen. Venturi mask delivers precise oxygen concentrations and are often preferred in COPD patients who require controlled oxygen administration. Non-rebreather masks are used during severe hypoxia and emergencies. And don't forget the reservoir bag should remain inflated during use and should be filled before applying the mask. The COPD patient can be rescued using the non-rebreather mask, but must stress that the patient needs to be titrated later or stabilized into a Venturi mask. High-flow nasal cannula systems deliver heated and humidified oxygen at high flow rates. These systems provide a more stable oxygen concentration, reduces the work of breathing, and helps clear up upper airway dead space. Dead space refers to the air in the upper airway that does not participate in gas exchange. Also, something to note is the air we first breathe in. It's not a lot, but the CO2 that doesn't make it out of this dead space is the air we first breathe in. This is a key concept during COVID-19 as we battle to maintain good lung capacity. Really sick patients didn't have much oxygen-making capabilities in their sick lungs. The non-working areas in the lungs also contributed to the dead space. PEEP played an important role by keeping these lower airway spaces in the lungs filled. Every little bit of space needed to be utilized by oxygenating it. Anatomically, dead space can account for 30% of the patient's tidal volume. A normal tidal volume is about 500 mils. That means about 150 mils of that tidal volume would be considered dead space. Since low-flow devices allow room air dilution, patients pull in extra air during that inspiration. High-flow devices better meet inspiratory demand and provide more concentrated oxygen. Oxygen should be titrated based on the patient's physical assessment, work of breathing, oxygen saturation, mental status, perfusion, and disease process. Increase the oxygen when the distress worsens or when oxygen saturation falls below the target. Then decrease the oxygen as a patient improves. Avoid unnecessary hyperoxia. If we are pinning admission, the patient needs to be stable on a nasal cannula. ER folks need to create goals by titrating and evaluating the effects till the patient is within normal respirations and SpO2. As soon as the non-rebreather goes on, the nurse should be thinking of ways to get it off by requesting medications to reverse the cause. These medications can include steroids, breathing treatments, and possibly Lasix. Documentation should include oxygen device, flow rate, FiO2, oxygen saturation before and after changes, work of breathing, respiratory rate, patient response, positioning, and provider or respiratory therapy notification when needed. On a side note, some COPD patients often require controlled oxygen therapy with targeted saturations that are typically lower than normal standards. Helpful positionings include high Fowler's, tripod, and pursed-lip breathing. And don't forget, excessive oxygen can worsen hypercapnia in some COPD patients. This is the old tip and trick to add to your clinical toolbox. Fans directed toward the face can help reduce the sensation of dyspnea in COPD patients. Facial airflow may stimulate the trigeminal nerve pathway and decrease the sensation of breathlessness and anxiety. Nebulizer treatments are used to deliver aerosol medications during wheezing, bronchospasms, asthma exacerbations, and COPD exacerbations. Patients should be monitored for respiratory improvement and medication side effects. Nebulizers are not always better than MDIs. Studies show, if properly used, meter dose inhalers with spacers can work as effectively as nebulizers for many patients. Nebulizers are especially useful when patients are fatigued, cannot coordinate inhalers, and they are in severe distress. Pretty cool, fun historical fact. The first nebulizers were developed in the 1800s and were handheld pump devices used to inhale medication vapors, long before modern respiratory therapy existed. Spacers for MDIs are extremely important. Without a spacer, much of the albuterol is lost in the mouth, throat, or air. With a spacer, more medication stays suspended long enough for the patient to inhale it correctly. Spacers help because they reduce the need to perfectly time the spray and breath. They slow down the aerosol cloud. They decrease medication impact on the throat and improve lower airway delivery. They also reduce side effects from swallowed oral medications. And now, time to test your brains. A patient with mild wheezing and shortness of breath is alert, cooperative, and able to use an inhaler correctly. Provider orders albuterol treatment. Which statement is most accurate regarding medication delivery? A. Is it one treatment of the MDI puff is equal to a nebulized treatment? Is it B? 4 to 8 puffs of an MDI is equivalent to a nebulized treatment? C. Nebulizers always deliver more medication to the lungs than MDIs with spacers. And D. Meter dose inhalers should never be used during respiratory distress. All right, folks, which one do you think it is? If you guessed or meant to choose B, you are correct. Studies show that approximately 4 to 8 puffs of albuterol from a meter dose inhaler with a spacer is just as equivalent as one standard 2.5 milligram nebulized albuterol treatment in many patients. MDIs with spacers can deliver medication efficiently when patients can coordinate the inhalation properly. It's also one thing to note too that each puff is usually around 350 to 400 micrograms. So it makes more sense that one dose of a nebulizer is 2.5 milligrams. Albuterol is a short-acting beta agonist bronchodilator used for bronchospasms and wheezing. Common side effects include tachycardia, tremors, nervousness, palpitations, and increased myocardial oxygen demand. Use cautiously in patients with acute coronary syndromes or arrhythmias. And don't forget, ipratropium is an anticholinergic bronchodilator used alongside albuterol during COPD exacerbations. It causes less direct cardiac stimulation and may be helpful when tachycardia limits our albuterol use. More current evidence, a newer 2026 systematic review summary found that adding nebulized ipratropium decreases our pediatric hospitalization risk with a relative risk of 0.76, meaning about 24% relative reduction in hospital admissions. Adding ipratropium to albuterol in moderate to severe pediatric asthmas does not replace albuterol alone, but it can reduce the chances of admission roughly by 20 to 30%, especially when given early in the emergency room. Alternatives when heart rate becomes elevated may include ipratropium-focused therapy, reduced dose albuterol, and levobuterol if approved by facility policy. Maybe even some corticosteroids or BiPAP, or maybe try some high-flow oxygen depending on the patient's condition. Nebulizers may worsen myocardial oxygen demand in patients with STEMIs, severe tachycardia, arrhythmias, and active ischemia. Key reminders today: always treat the patient's clinical appearance and work of breathing, not just the monitor. And reassess after every oxygen adjustment and document all interventions clearly. All right, folks. Don't forget your keys, y'all. Any questions?